We are going to record this webinar. Welcome to Accessing Behavioral Health Treatment for People Experiencing Homelessness, Navigating Enrollment and Services. My name is Leslie Clark, and I am the Training Director for United Homeless Healthcare Partners. And we are very pleased and honored to have to be doing this webinar with our partners, LA Care, HealthNet, the Department of Mental Health, Los Angeles County Department of Public Health and Substance Abuse Prevention and Control. We have a very full webinar today, and we'll have lots of people online. So everyone will stay muted until it is time for the Q&A session at the end. So you know we will have all of the slides and the handouts online at our website at uhhpla.org under resources. So you can access those handouts right now, and the webinar will be up shortly. Questions for our presenters can be sent through the chat function. So please go ahead and type those in, and at the end we'll get to your questions. Let me welcome our presenters for today. Oh, just a moment about the UHHP mission for those of you who may not know about UHHP. UHHP is a unified partnership of organizations that advocates for effective policies and increased funding to ensure permanent housing and healthcare services for residents experiencing homelessness in Los Angeles. UHHP provides leadership, builds collaboration, and enhances services and provider capacity. UHHP is facilitating this webinar as it is our mission to build collaboration capacity among homeless services providers in Los Angeles. And we've had a lot of input and requests over the past year or so for information like this. So we're happy to be doing this webinar. We have done one webinar on Medi-Cal enrollment, and the information from that webinar is also at our website. So today we won't be taking general calls about Medi-Cal enrollment, but you can access that information on our website, unless it's related to behavioral health services. This webinar is focused on behavioral health services, and we're pleased to have our partners with us. Our presenters today are Dr. Susie Matsuda, the Clinical Director for LA Care, Dr. Anthony Rizzo, Director of Clinical Services for HealthNet, Amber Anderson, Training Coordinator for the Department of Mental Health, and Dr. Gary Tsai, Medical Director and Science Officer for the County of Los Angeles, Public Health, Substance Abuse Prevention and Control. We're going to go ahead and begin. Our objectives for today are to review Medi-Cal managed care and the behavioral health network in Los Angeles. For those of you who are out of town or out of state, this is primarily focused on Los Angeles, but you may find some valuable information. We'll also help you know how to work with LA Care and HealthNet specifically to help your clients get access to services. We will talk about understanding how to connect with DMH and DPH and the special population programs that DMH offers. We'll review how to access substance abuse disorder services, as well as drug Medi-Cal referral care and coordination with SAPC. So I will begin with Dr. Matsuda, who is the Clinical Director of the Behavioral Health Department Health Services of LA Care. Let me bring Dr. Matsuda online with us. Dr. Matsuda joined LA Care Health Plan as the Clinical Director, as the Clinical Director for Behavioral Health Services in February 2014. Prior to joining LA Care, she had worked for Orange County Healthcare Agency Behavioral Health Services for almost 20 years, providing care to people living with severe persistent mental illness. She was the OC BHS Multicultural Development Program Coordinator after 7 years serving as Mental Health Clinic Service Chief She completed her doctorate in clinical psychology from the Chicago School of Professional Psychology, her master in social work from CSU Long Beach, and is also licensed as a clinical social worker. Dr. Matsuda is also a talk show host on Vietnamese radio and television program for 15 years and is a guest speaker and lecturer at high schools, universities, and conferences on ethnic, mental health, and cultural competency issues. Dr. Matsuda received the 1998 Asian Pacific Islander Community Service Award at Cal State Long Beach Social Work, 1997 Citizenship Award, and the League of United Latin Americans, and many other awards. In 2004, she was selected by the Orange County Register as one of the top 30 Vietnamese Americans to watch. So we are very honored to welcome Dr. Susie Matsuda.
Thank you. And I'm going to go over the behavioral health services for LA Care members. So then you will be monitoring the screen, right?
Yes.
Yes, please.
Yes,
okay,
just let me know when to change it.
Okay, so we're going to go to the next slide, and it's my privilege to share with you the behavioral health system of care for LA Care members and how we have worked together with our partners, DMH, DPH, and our vendors, Beacon, and also on our medical side, or working with PPGs and IPAs to develop a system of care for behavioral health for our members that would help meet the needs of members in all different levels of care and with diverse services that they may often need. So let me start with us all. So we all know that starting January 1st, 2014, there's a Medi-Cal, the expanded mental health services for pension, and the services, it used to be for mental health folks who do not have public health insurance. If they have Medi-Cal only, the condition getting into the severe, then they get to the county specialty mental health. As far as for folks who are mild and moderate, who have public health insurance or Medi-Cal, there are limited resources out there for folk with mild to moderate. But starting January 1st, 2014, now the managed care is responsible for mental health services for folks who mild to moderate. And so we have we contracted a network of private psychiatrists and private therapists that is managed by Beacon to provide those services for LA Care members with mild to moderate condition. So those services is diverse. It includes individual, group mental health evaluation, psychological testing, outpatient services to help monitor medication, outpatient lab, medication, supplies, all that. Some of this is performed within the PPG, meaning preferred physician groups, IPAs. I will go into details later. And also outpatient psychiatric consultation. So the expanded mental health services include all of that, and even a PCP screening and brief intervention also in the package included at the PCP office for folks with mild condition. And the screening, behavioral health screening, is also included in package for PCP to do behavioral health screening and alcohol use screening at the PCP level. So I'm details of that information in a bit later. As far as for specialty mental health, there's no change. It is still carved out to the county for LA Care. For LA County, the specialty mental health is still with Department of Mental Health, and for substance use only is still with SAPC. That is substance use prevention program within the Department of Public Health. So that's where it is. Let's go to the next slide. Thank you. All right. So I'm going to save this later for Dr. Sai or for this slide talking about the substance use services. So this service is covered by SAPC, by DPH, and Dr. Sai going to go into detail with you about this and the update status of cover benefits a bit later. Would you go to the next slide? Okay, this is as a matter of fact, we have actually an updated version that we added the autism, the autistic spectrum disorder services for LA Care members, the contact information for them, where to call. It's actually called to LA Care. We have a team of staff who get their call, instruct them through the comprehensive evaluation process, what they need to do, and what a document needs to get together so that we can authorize the services and all of that. So this table that you see here do not have that autism piece. I will be sending it to you, a new updated grid that included the ASD services for you. In a nutshell, this is the table, the grid that addresses the system of care in for LA Care members, and it's talked about services that included at the PCP level. So as you know, when mental health services expanded, we also want to count services that included in a PCP level for mild condition. And for mild condition, and the one thing that we excited about, and when we go out there with the preferred physician group and the independent physician associations group that manage the network of the PCP and specialists and all that, we talked to them about PCP office, primary care physician, doing behavioral health screening at their office. So the routine screening for emotional health and substance misuse is included in the package that we that we work with PCP. And in outpatient medication for mild conditions, we can provide that treatment, monitoring for mild condition, providing counseling, support, education, and again, screening for substance use expert, and provide a brief intervention if folks, for those who meet that mild level of care, and managed care cover that. And so, and then if the member needs more than just a brief intervention after the expert screening, that need to be moved to a DPH, and I'll be speaking about that in a bit later. So that's the first column. The second column is our LA Care non-specialty. Non-specialty, we talk about folks with mild to moderate behavioral health risk. So these are the folks who probably able to maintain their day-to-day functioning, but they do have mental health symptoms that they do not need intensive case management, but they probably just need medication and therapy, and more in the private network. So Beacon is it's managed this network, and the service provided by Beacon network is again an individual group, like I did mention, psychological testing, outpatient site consultation, meaning a lot of there are members who place in long-term care or institutional care, and they want site consultation, and oftentimes they call our network. We said no, Beacon is only providing outpatient site consultation only, and they won't be able to do that. And in institutional care, that is included in the PPG physician group responsibility and authorization. So that's on the Beacon side. Beacon side non-specialty would also provide outpatient lab supplies and supplements, and so that's the services. And then this is for children and adults in managed care, and for those who meet medical necessity or EPSDT, early prevention, screening, and referral to for developmental disorder and referral to treatment. For those folks, these are for those who meet medical necessity for EPSDT or for mental health services. For children and adults that meet the mental health service, mental health that need mental health care. So now with folks who have more intensive, need more intensive case management, that have more severe functional impairments, let's say lost a job because of due to their mental health condition, or become homeless because of mental health condition, or many other functional impairment due to mental health condition, needs intensive case management. We consider that to a specialty mental health. And as you all know, specialty mental health have an outpatient services that provide medication, mental health assessment therapy. They also included day treatment services, day rehab, crisis intervention, crisis stabilization, targeted case management that I have mentioned, and therapeutic behavior services. They also, specialty mental health also included residential services and also inpatient services. So, it's a managed care health plan only for the outpatient piece. Inpatient, residential, and more intensive case management mental health services is vested with the county Department of Mental Health. And then for the last box in yellow is all for the folks who have substance use only, and these are the services that cover, and Dr. Sai will go much more into detail about those services. And the first top box in colors, these are the phone number access for member of LA Care to access to these services depending on the level of care. So that's where the whole spectrum from of care from mild to moderate to severe behavioral health risk. Okay, so feel free to let me know if you have questions. I can respond. And so let's go to the next slide, please. This is the Health Behavioral Health Network, and for LA Care, you see there is the community clinics providing physical health, and then FQSC providing physical health. Some FQSC may have a non-specialty that we are working with them. Some of them now they have contract with Beacon to provide a non-specialty level and provide much more integrated care within the federally qualified health clinics, the FQSC. And then we have behavioral health provider network that with Beacon and pink box there. And then community clinics, and some community clinics have specialty mental health that have contract with the county. It's called legal entities. And then we also have primary care physician is on the LA Care Physical Health Network. And so for LA Care, the network of beneficiaries that included FQSC, behavioral health provider, private network, Beacon, community clinics, and primary care physicians. So that's where we are. And so we also have and for LA County, we have some members that have partners that have legal entities that now also sign up contract with Beacon LA Care to provide non-specialty. So they have contract with the county for specialty called legal entities, but now we're working with them to have also contract with non-specialty so that the member may be staying with one clinician and able to receive the wide range of services along the continuum of care. So they don't have to be moved to, because you get better now, you need to move to a different clinician because we're not on that non-specialty network. So we're hoping that the member will be staying with one clinician from the back end, depending on the services you bill differently. If it's specialty, you bill to DSP. If now it's non-specialty, the member get better, you see the member less, the service is more non-specialty, you bill Beacon. So we're working with the county legal entities to work with them to have contract with non-specialty as well. So that's where we are. And then in the LA County, we have the inpatient service, and then the outpatient clinic and residential treatment that managed by the county. At County DPH, there are other services that managed oversight by DPH, and Dr. Sai will probably go into more detail with that. And I'm sure a partner here with DMH are probably going to be able to explain more on the DMH network. Okay, let's go to the next slide.
Oops.
Okay, so this is a, we call it, it used to call it universal screening form, meaning because it's designed by DMH and with all the input from the health plans, and it used to be also HealthNet. Also sign on this the screening form as well, and so this screening form is have different purposes. For DMH is, they asking folks to use this form to make a referral to DMH for urgent appointments. For non-urgent appointment, folks can call DMH access directly, that they don't have to use this form. However, there are partners, especially for the physical health side, they're using this form and looking at the algorithm here to help them identify, okay, where the member may fit. However, we tell them, if you're not sure, just call Beacon. Beacon will provide the screening, and we'll do the warm handoff if the member needs the services. With the non-specialty, Beacon will take care of it. If it's specialty, will be moved. They will do the warm handoff over to DMH or DPH if substance use only. So this screening form that we're using the algorithm here just to help folks in case if they have doubt, which level the member may be needed, and it have list, check box on list A, check box on list B. List B is more for more severe functional impairment, and based on list A and list B, where should you refer the member through that spectrum of care? So that's what we come up with, and I just want to give you a snapshot of the screening form, and I think right now it's still we are going to be looking at it and making sure that it serves a single purpose, so it makes it easier for folks. So that's where, in a nutshell, for the screening form. I wonder if you have questions, and I can respond. Let's go to the next slide, please.
And Susie, the screening form is on the website, so people can get the full form there.
That's right. Yeah, right. Yeah, that's right. Can you go to the next slide? I want to go through quickly so other speakers have a time for their presentation. The screening form also have the instruction, and part of the instruction also because for LA Care we have plan partners. So our plan partner is Anthem and Care First. So we, in this instruction, on the non-specialty side, Beacon taking care of for LA Care and Care First for non-specialty. But Kaiser and Anthem have their own non-specialty network. So in the instruction here, we also provide contact for non-specialty for those plan partners. Would you go to the next slide? You will see that. Oh, this here. Oh, it's not. This slide doesn't have that neither. Okay, so the screening form has some updated, and then the behavioral health spectrum of care table also have an update. So I will be sending you those two, and I apologize that this slide is not all updated. The slide that you're looking at right now is basically information for LA Care Behavioral Health team that we designed a team to support providers. So to help provider on the physical health side to navigate the behavioral health system of care, the whole spectrum of care. As you know, it used to be as an operation, it was in silo for physical and behavioral health. So now we wanted to, bridge the gap, provide integrated care, and increase communication between provider from physical to behavioral health, and having like a team, the care team for member in the whole person care focus. So behavioral health team in LA Care want to bridge that gap and want to provide support to providers on both sides. So in case if there is a problem with access to physical health, from access to behavioral health, or there's an issue with level of care transfer, all of that, and facilitating of care coordination, all of that. So behavioral health LA Care would be the bridge for when there are problems. So, and the contact behavioral health phone line is there. there is a mailbox that you can just email us directly called behavioralhealth@lacare.org. And then also there's a website, the toolkits for providers. In that there's screening form that I just presented. There is the behavioral health system of care table, expert PowerPoint about screening for alcohol use, and all of the benefits and all that. So you can find that there. So I think that's the last slide for this. And again, I just wanted to repeat to you that we're working with the physical health side to promote, behavioral health screening and also substance use and alcohol use screening. We let them know out there there's no wrong door. We're asking them to call Beacon so that the member can get access to behavioral health services, get screened from there. And we also tried the pilot on e-counsel and e-management at this time, and hopefully in the future when it's fully launched, that it will be more integrated care and communication between physical and behavioral health. And so that's where we at this time.
Thank you very much, Dr. Matsuda. There was one question that you may be able to answer very quickly. You referred to EPSDT. Would you explain what that is?
This is the screening for all children in PCP, primary care physician. We are trying to work with them and have them doing the screening, the physical health screening for young people, and also behavioral health screening, and also some of the screening for developmental disorder, and refer to services, refer to regional center, refer to children's services. So it used to be it's called early EPSDT. I apologize that I do not all well versed when it comes to acronym. It's early prevention, screening, diagnostic, and referral for kids. Yeah. So we're hoping that's happening at the PCP office, and we're working with them. And most updated, we also wanted to included some trauma care screening as well. But that's in the just not in the launching yet. Yeah.
Great. So direct questions to Dr. Matsuda through chat, and she can answer those at the end of the presentations. We'll go to Dr. Rizzo next. Dr. Rizzo is the Director of Clinical Services at the Huntington Beach Service Center of HealthNet, and he oversees outpatient and facility-based clinical services at the Huntington Beach Call Center for MHN, the behavioral health subsidiary of HealthNet. In his most current role, Dr. Rizzo has been leading the rollout and implementation of Medi-Cal expansion and the service team's role in the Duals demonstration project for MHN. He facilitates co-management and care integration activity between HealthNet Medical and MHN, and oversees MHN's disease management initiatives. With over 25 years of experience in the behavioral healthcare industry, he has worked collaboratively on case management initiatives to reduce readmission rates and improve quality of care. Before joining MHN in 2003, Dr. Rizzo worked as a staff psychologist and program manager at Kaiser Permanente Medical Center in South San Francisco, where he managed all aspects of outpatient psychiatry department operations. Prior to this position, he served as program manager and clinical psychologist on the staff of the Group Health Cooperative in Spokane, Washington. In his earlier career, Dr. Rizzo was also program director and clinical psychologist at Scripps Clinic in La Jolla for 10 years, where he co-developed the intensive outpatient program for substance use disorders. So we're very happy to have Dr. Rizzo and his expertise with us. Dr. Rizzo, are you there?
Yes, Leslie, thank you very much for that warm rollout. And it's a pleasure to be here. Can everyone hear me? Are we okay on audio?
Yep, you sound great.
Okay, thank you. We can probably go on to the next slide. So as an introduction, I've been with HealthNet over 10 years, as Leslie explained. And ironically, I was a provider for HealthNet when I was back at Scripps in the 80s. And so I wanted to start with that point to emphasize the fact that HealthNet has been a leader in California, but even nationwide, even though we've reduced our footprint over the years to focus primarily on servicing HealthNet California members. And in that, we have a very integrated system of care. So MHN is a wholly owned behavioral subsidiary of HealthNet. Our headquarters are in San Rafael, California. I did work in that service center after I was at Kaiser for a while. And our basically position is to have a network of behavioral health providers to complement the medical providers on the HealthNet side to deliver clinical-based services and enhance the lives of all of our members. We are URAC accredited, we're NCQA accredited, we're licensed under Knox-Keene, and we are specialized to treat behavioral as well as chemical dependency. Although the focus of today's meeting is for the Medi-Cal expansion project that Dr. Matsuda said began in January of 14, we are a full-service managed care company and do have a whole team that I oversee that manages facility-based care as well for both behavioral and substance abuse services. And the point is, I don't want to overstep Dr. Matsuda's or repeat what Dr. Matsuda said, but she very well presented the fact that the development of the rollout was to offer an added layer of treatment of mental health services for Medi-Cal members through the managed care networks. And the nice thing that we had was that we offered our entire network across over 5,000 providers to join Medi-Cal. So we had a very good response. We are still developing that network as we speak, recruiting actively in our provider relations department. And as already covered, the services cover mild to moderate behavioral mental health benefits for Medi-Cal members. However, I want to say, and I think she covered it well as an addition, that Dr. Sai may cover this on the county side, is that we work very collaboratively with the county, and Rogelio can probably step in a little bit. We meet weekly with Rogelio, who has interactions with the county, and go back and forth with cases that need further care, specialty mental health services, and then look at providing the aftercare or the step down of treatment if the member is ambulatory, able to attend to ADLs and function in an outpatient office-based setting. And so therefore it's not a hard line. It's like we basically work back and forth. So it's not like we're going to say, okay, this is only mild to moderate, that is specialty mental health. Okay, next slide, please. Okay, so our national network is over 40,000 providers and 1,200 facilities. Our individual practitioners are MDs, DOs, nurse practitioners, PhDs, master's level therapists. And as I said earlier, our facility network is all levels of care at every point in the hospital-based system, as well as office-based intensive outpatient programs and partial hospitalization programs. Next slide, please. Behavioral health services are, typically sessions with a counselor, therapist, psychologist, or psychiatrist, and we've included the facility-based overview. Case management services, we do have our care managers that I oversee working with higher risk members. So we do a stratified assessment, a full clinical assessment. We're a paperless company, and assess for the array of support members functioning in addition to just the acute need for behavioral office-based therapy. And as I said earlier, we do monitor with the counties the discharge of members from acute facilities that the county manages and try to hook them up to outpatient office therapy when appropriate, if they're able to ambulate and function as any of us would when we access behavioral health services. And MHN is also known in basically in the industry as being a leader in EAP, and we have several of those programs nationwide. Okay, next slide. Okay, so we developed, as all the managed care plans did, an MOU for the expanded benefit service interface. It delineated specific roles and responsibilities that the county mental health plans would do and that the managed care plans would do, who meet medical necessity for the added layer of services. Our entire PMP database, this is an incredible amount of revision, was done to incorporate the population and meet its needs as needed. And let's see, okay, I think we can go to the next page. And liaison, actually behavioral health liaison is Rogelio, who works with San Diego County in particular. I don't know if you really want to introduce yourself briefly at this point.
Well, thank you very much. We have liaison to all our counties, in particular here in Los Angeles. We're just in the process of assigning a new liaison to do the interface with the mental health department. But anyway, I've been the lead on for the liaison functions across the state, and I'm based out of San Diego. Have had experience in actually negotiating the original MOU in Medi-Cal managed care with Los Angeles County. Thank you.
Thanks, Rogelio. So one of the features,
Oops. Dr. Rizzo?
Are we okay?
Yeah, go ahead. Sorry.
Thank you. We're an open access system, meaning that members are issued insurance cards, as we all are, and they do not need to access care by getting referral from the primary care physician. So they basically call the number on their insurance card, and they will be directed first to HealthNet, customer service, even though MHN has our own customer service department. And they are able to use an IVR, which is, the menu screen on the phone, to come directly to mental health if they want. If not, they would go through the medical customer service department just to ensure that the member has a PCP, is involved in the system, is enrolled, in other words, all the paperwork is in order, and then referred over to behavioral health. But they can be, we have our own customer service department and can be referred directly through the menu on the when they call. There is no, we try to remove every roadblock possible to access our customer service department. Customer service are paraprofessionals in our building, and they do a risk assessment, which is, again, a paperless assessment, and all calls are immediately transferred to a licensed clinician, LMFT, LCSW, for assistance when risk questions are endorsed, or if the member is experiencing difficulty getting a provider. In other words, maybe the provider is not accepting new patients and we need to update our database. And then we would do what's called a PAC, which is a provider availability check, where we have a whole team that would do a hand-tailored call-out for the member to find a provider and then loop back to the member and provide either the appointment or the provider's telephone number. We would do warm transfer if they want, and then engage the member in treatment. So our major goal is to not leave any member stranded with a handful of referrals and not know which next step to take. We coordinate our service delivery with the county mental health departments, as I said. We have information exchange, and we do have referrals to the county. We have developed forms now with almost all of the counties. Some are in the last drafts as we speak, similar to the one Dr. Matsuda put up, where we kind of agree what constitutes a mild to moderate condition versus a need for specialty mental health. So we have kind of part of the MOU where we would have a mutual understanding of where the member should enter the door for services.
Okay, so you said that you were from the department,
So,
that you need to sign.
Dr. Rizzo, hang on one second.
What?
Sure.
Okay. Dr. Rizzo?
I'm here.
So, okay, so I'm not able to mute everyone and get you back. So just want to make sure everyone who is on the line, please mute yourself or your computer. Thank you, Dr. Rizzo.
Okay, hold on. Okay. Hold on.
I thought that was a question. Okay, I didn't know.
I know, hold on. Hey, Bob,
So go ahead, Dr. Rizzo. We're just going to have to talk over that until we can get that person to mute.
We're going to be in LA. Right.
Right.
Okay.
Oops, sorry. I just skipped ahead.
All right. So I think as Dr. Matsuda covered, one of the unique aspects of the medical expansion was that our entire network of primary care providers were basically educated and brought into the mix of how to provide service for the expanded service for Medicare members. So a large piece of that involves, as she was saying, the early periodic screening, diagnostic treatment, assessments. They do brief behavioral health counseling. They're able to do brief interventions for substance use disorders. And this is all, of course, dependent on their level of expertise and comfort. But many of our providers on the medical side have taken this on and work collaboratively with myself and our department to then turn the member over for behavioral health services when indicated. And they're also very adept at contacting the counties for, say, substance use services or specialty mental health services when they're deemed appropriate. I sit on about 4 to 5 meetings per week with clinical rounds with HealthNet, case managers, and medical directors. And we critical case, basically cases that are on the radar of their case managers, as well as my case managers, and talk about getting the care integration that's needed to its peak form, and then also make a decision whether at this point the member may need to be referred to the county. We have all hands on deck, basically 4 to 5 meetings per week, discussing both the Medi-Cal expansion members, as well as Leslie mentioned earlier, we're heavily involved in the dual demonstration, which is the many members. Okay, next page, next slide. This is our access number for MHN. So this number would come to us directly. We also have a physician helpline. So many of our both medical physicians as well as our behavioral providers can call this number and arrange a consult with one of our psychiatrists and discuss any issues related to the outpatient management of the member. So possibly a PCP, they're stuck on some medication issues, or it feels like they can treat the member for major depressive disorder, but yet they want to run by some medications and determine the appropriate dosing. So though we do have our physicians readily available, appointments are set up through a medical secretary. This has been found very useful for both the medical doctors as well as our own clinicians that sometimes don't have a psychiatrist that they work with directly, master's level clinicians, and would like the expertise of a psychiatrist. Okay, and this is the HealthNet number. So on the insurance card, as I mentioned earlier, this would be the number that would be listed there. But we do have open access, so the member may also call the first line number for direct access to MHN. Okay, next slide.
Dr. Rizzo, I think we may have skipped a couple of your slides when we...
Look, I thought so. I thought we missed something.
Yes, I think when we were bringing Rogelio online, I think we might have missed a couple of slides. So I'm going to go back to the network slide. You covered that.
Okay, I think we got this.
So, Bobby, do you think you can explain it next week? I got Amy's email. Yeah.
Participants, please mute yourself.
Okay, the last bullet there was about Rogelio, the liaison structure. So next slide. Direct access, we covered that. I thought we had more slides. Let me see. This is our contact information. Okay. It
was just these 6. Anything that you would like to share in particular about serving homeless clients?
Well, I think in that regard, we do, that's what I was mentioning earlier about our case management. So we do realize that it's for many of our members to attend to ADLs or be able to have a locale to conduct business, even to call us. So we make it possible to contact members via the best available number. And I do know that some of our medical groups, like I think of Regal off the top of my head, I'm not sure if I saw Regal somewhere in the presentation material, actually is providing cell phones to some of the members that are homeless to have a point of contact. So that's the latest we've been able to do. And we're also working on telehealth options, similar to what Matsuda said that Beacon is working on, where members may be able to access services with our network through computer and e-services, perhaps through one of their primary care office locations. In other words, if they couldn't get to the provider's office, but yet they could, a behavioral health provider, but yet they could get to their PCP's office, we could possibly try to engage them at that level. So this is all in development as we speak.
Okay. Great. And a quick question, someone asked, are the liaison or the case manager a good point of contact for hospital social workers to talk to about an individual who's not having mental health or behavioral health needs addressed?
Medical social worker on
a hospital social worker. Should they talk to your case manager or the liaison?
Absolutely, call us. Absolutely. Speak to one of our care managers, case managers, and we would be able to assess what the member needs. If the social worker has the individual there, we could possibly get them on the phone or do an outreach call.
Okay. Wonderful. Anything else, Dr. Rizzo?
You know, I think as I want to just echo what Dr. Matsuda very well covered, is that we are also very free endorsing the no wrong door concept. There's no wrong point of access. We are very, very integrated. I think one of our specialties is that as a managed care plan, there's a seamless discussion between medical and psych, so that when our doctors pick up on something in the 15-minute session they have with the patient, they're able to get on the line or have their case manager call us. All of our medical groups have case managers and call us directly. They're very familiar with who we are and talk to one of the care managers directly. So we're really just trying to knock down the walls and access the needs of this critical population.
That's terrific. Thank you very much, Dr. Rizzo.
My pleasure. Thank you for having me. Please feel free to chat me, or I have my email, I think, up in the attendee list. So if you want to contact me, I'd be more than happy to speak further.
Terrific. Another quick question you might be able to answer before you jump off, I know you may need to go, is are DMH, DPH, and the managed care plan staff able to communicate with each other to coordinate without a release of information?
We basically do ask for the release if the member is there. I think in the, Rogelio, if he's still on, may be able to address this. In the MOUs, there was an agreement that HealthNet would receive discharge data from the counties. I believe Optum was involved in this for San Diego County, I know. And that was worked out in terms of all the legalese to it. So we do get discharge data on members. For active collaboration, we would ask for a release.
Okay. And Dr.
And obviously, if the member is there with, like, say, the hospital social worker, that can be done that way. If the hospital social worker wants to give us information, we can take the information, possibly send the release back to the social worker. Cold calls to members have not worked well for us in the past, and so that's probably not a road we'd go down. We probably would ask for at least the minimum of verbal consent for contact.
Okay, and Dr. Matsuda has a response to that as well. Dr. Matsuda?
Yeah. For LA Care, we working with DMH and DPH on the, we have the system level. I mean, of course, you know, with CMC, probably going to be the same with HealthNet too. We actually meet with DMH every other week on the clinical management team and on the program management team meetings that we go over these, go over the system of care, having to do with access, transition of care, and collaboration, exchange of information. And so we have every other week folks on the administrative side and the clinical side working together on a day-to-day basis. It's an active communication. I give you an example. We have for the Medi-Cal, we have member with CMC, CalMedi Connect, and then Medi-Cal, and then the commercial line of business. But we look at let's say we have member who high site admit, and so we pull those members out, and then we get together interdisciplinary care team where we include representative, include DPH representative, other folks from the medical management side, folks from a behavioral health side, and also community service if that's relevant. And then so we pull together so that we can have a plan, pre-planning before member discharge to engage member, after discharge to services and help to reduce the readmission. So that's one of the ICT. There's many other ICT we targeted for different needs. And so we're working at the operation clinical level, but also at the administrative level, very closely with DMH and DPH together for the Medi-Cal population and also for the CMC.
Thank you, Dr. Matsuda. And thank you, Dr. Rizzo. Thank you to our participants for tolerating some of the noise background. For some reason, GoToMeeting is not letting me mute everyone and then let our speakers on, but we are going to try again. We're happy to have Amber Anderson with us today. Amber is the training coordinator for the Los Angeles County Department of Mental Health Program Support Bureau, MSHA Implementation and Outcomes Division, Amber started her career at Mental Health America of Los Angeles at the Village. During her time with Mental Health America, she worked in the Homeless Assistance Program and was a case manager on a full-service partnerships team. After attending Cal State Long Beach, where she got her master's in social work, Amber became associate director of an FSP team at Mental Health America. Amber was then promoted to director of field capable clinical services. In her current role, she provides training to MHSA innovation providers, is the lead for countywide services, area navigation, and impact teams, and she provides lead support and oversight to the FSP integration pilot program. So Amber knows a lot about working in the field with homeless as well as MSHA services. So welcome, Amber.
Thank you for having me.
We're so happy to have you here.
We can go ahead and go on to the next slide.
Okay.
So today I'm going to go ahead and review the Mental Health Services Act, also known as MHSA. MHSA focal population, service area navigation, service area by age group, community services and support, our PEI, prevention and early intervention, innovation, countywide services, and most importantly, how to access your service area navigation teams. So, and throughout the I'll also talk about how to refer to some of our most requested services. LA County Department of Mental Health is the largest county mental health department in our country. Under the Mental Health Services Act in fiscal year 13-14, 102 and 390 30, oh gosh, I hate doing numbers. You can see them on your screen. We served a lot of people over the course of the last fiscal year, and this is just to show you kind of the magnitude of the services and the amount of people that are being triaged through LA County. Next slide. This is a little bit of background on what Mental Health Services Act is. It was passed in November of 2004. It's the millionaire's tax, as some people call it. Taxes 1% of people who make over $1 million to fund specialty mental health services and the expansion of mental health services for LA County and for the state of California. Who it serves all age groups from children to older adults. Next slide. MHSA's focal population is we serve clients who are diagnosed with mental illness or serious emotional disturbance and are receiving services but are not provided necessarily appropriate for the opportunity or to support their movement and recovery. And that's what we call the underserved. So people who are receiving services but aren't getting the needs that quite meet their quality of care or their need. So next. The other focal populations served through LA County Department of Mental Health are the unserved. Those are the individuals who have serious mental illness and serious emotional disturbance and are not receiving mental health services at all. A lot of these individuals receive mental health services through community or crisis-oriented people going through emergency rooms and jails, or a lot of times you guys going out there and doing the street outreach to the folks. Next slide. So with the magnitude of LA County and the size of how big our services are, we had to get them broken down into the different service areas. In LA County, we have 8 different service areas, and each service area has a navigation team. The navigation team is your no wrong door approach. They're the ones that help guide you through the services and can link you to the appropriate level of care based off of what that geographical area's needs are and what services are provided in that area. The other role of the navigator is to ensure that individuals are linked to services and to follow up with that linkage. They also recruit community-based and professional-based groups. A lot of people, I don't know how many of you attend SAC meetings or provider meetings in your service areas, but that's also a function through the service area administration team, and that's where the navigators come in. The navigators are your gateway to the accessing DMH services. So if you ever wonder or have questions about where does this client belong, how can I access that, always start with your service area navigator. And I'll talk further in my presentation of how to access them, but they're your gatekeeper to all of our services in the no wrong door approach. Next slide. So now I'm going to go ahead and talk about the services available by age group. Most of you probably aren't outreaching to children, but I wanted to include it in there so you know what services we have available. I will go into detail about how to refer to our FSP and FCCS and PEI programs. Another unique program that we have for children is our TBS program, our Therapeutic Behavioral Services. TBS cases, the clients have to have an open probation or case, and those services are equivalent to the level of FSP or full service partnership, which I will go into more details. Programs under the Child Welfare Division require the child to have a DCFS case, and referrals would be made through the DCFS care manager. So if you're working with parents who have a DCFS case, you can talk to their case manager to refer their children to the Child Welfare Division. Next slide. The next guess is our TAY age group, or transitional age youth, and that ranges 16 to 25. Same with TAY, we have FSP or FCCS. A unique thing, TAY drop-in centers are unique to that age population. There's 2 drop-in centers in LA County, and that is where TAY can come in, shower, bathe. They don't have to be enrolled in services, but it's a place where they can go to talk to people, and those are in service area 2 and 3. We also have a unique program for TAY, which is the emergency shelter program. It's a 30-night stay shelter program for our transitional age youth. TAY themselves need to call that number on your screen to be able to coordinate an intake to see if they're eligible for the TAY emergency shelter program. So if you're a case manager and you call that number, they will not accept your referral. The referral needs to be done by the TAY receiving the services. The other unique service, yes.
Amber, excuse me one second. Mr. Garcia, please mute yourself. Juan Carlos Garcia, please mute yourself. Go ahead, Amber.
Okay. The other unique service that's available for the TAY age group is TAY service area navigators, or system navigators. Along with the service area navigators, TAY has system navigators assigned to services whose primary role is to assist the youth to navigate multiple systems, not just DMH. And then the other unique program for TAY is the independent living program. Those are in service areas 2, 3, and 6. And these provide housing opportunities and supports for TAY who are exiting out of DCFS or probation foster care. A lot of those TAY who come to your door because DCFS no longer is providing support or services may qualify for the independent living program. So that's something to look into. Next slide. So for adults, again, I will go through PEI, Full Service Partnership, FCCS as well, but there are some programs that I wanted to highlight on the adult slide. Our adult age group is 26 to 59. And the 2 unique programs that I wanted to talk about in this are the CalWorks programs, which are responsible for monitoring CalWorks mental health program and the clinics agency-wide. So DMH has that service. The other one for adults that's unique is the court liaison program. And we have that in 20 courthouses countywide. And the object of that program are to increase coordination and collaboration between criminal justice and mental health systems to improve access to mental health care and supports while receiving a continuity of care. So lots of people coming out of Twin Towers, Linwood, or just have an open court case will get a court liaison social worker to work with them and the courts on what would be appropriate sentencing and then treatment after sentencing. So those are unique to our adult program.
Yeah.
Next slide. Our next slide is our older adults, and older adults captures anyone 60 and above. The unique program here that I'd like to talk about is our Genesis program, which you can see the evaluation of it. And Genesis is our countywide older adult program. They use service extenders or peers to provide services, and they also have a focus on hoarding. So it's a unique program for those who are working with older adults who may be at risk of losing their housing due to hoarding issues. Next slide. So CSS, the first wave of MHSA funding is the community service support, which includes FSP, FCCS, and the other services we previously discussed. I'm going to go into FSP by age group. In your slides, you have child and TAY. I'm not going to focus, and older adult. I'm not going to focus on those focal populations. They're there for your reference, but most of you are providing adult services. So I'm going to go into what adult FSP referrals would look like, what the process is, and who would qualify for that. Next slide. So FSP is the highest level of outpatient care provided by LA County Department of Mental Health. Each age group has a specific population to be eligible for services, like I said previously, and we'll go through the adults and how to refer. So all FSP referrals are done through the service area navigators. Programs, or they're done directly from the providers outreaching clients, but they still send the referral through the navigation team. And so we'll go into that process in more detail. FSP is like I said, our highest level of mental health services prior to hospitals and patient hospitalization. The client is intensive services. It has a whatever it takes model. It's comprehensive, low staff ratios, 1 to 15, and it's 24/7 support for consumers. I'm sure most of you are familiar with the service. So the first couple slides just are for your reference. So this talks about the child and TAY focal population. Next slide. For a child to be eligible for mental health services, they have to have a serious emotional disturbance. Since children aren't diagnosed with Access 1, next slide.
Oops, sorry, Amber.
That's okay. So since children aren't diagnosed with Access 1 diagnosis, they have to have serious emotional disturbances. And below is the definition of that. Next slide. And for our TAY, they need to be SPMI, which is severe and persistent mental illness. And there's a definition of what severe and persistent mental illness is. If a TAY is over the age of 18, they will ask for an Access 1 diagnosis. That's a Medi-Cal approved. Next slide. So this is where I really want to focus some of my time on is the adult focal population and diagnostic criteria to be eligible for FSP programs. Since the LA County is so large, when FSP rolled out, we had to put specific time limits on to the focal population due to the magnitude of people who would be eligible for the services at a statewide. So for LA County, clients must have the total number of 120 days homeless in a period of a year. If they don't have at least 120 days, they would not qualify for FSP services, and that's self-reported. Or there's the chronically homeless definition, the HUD standards, that also qualifies for FSP services. Or the client has to have 2 or more episodes equaling 30 days of incarceration in the past year, transitioning out of a state IMD or state hospital, but the client has had to have a minimum stay of 6 months. And they are frequent users of hospitalizations or emergency rooms. Client must have at least 10 episodes. So they have to go in and out at least 10 times in emergency rooms or urgent cares. That's for urgent cares. Or they have to have a minimum of 2 hospitalizations totaling 28 days in the last year. Or they need to be living with family members, and without that support, they'd be at risk of homelessness, incarceration, or hospitalization. When referring to FSP services, because there's a lot of things that go into it, the best thing that I can encourage all of you to do is, prior to making a referral, call your service area navigator, talk with them about the case, talk with them about what services would be appropriate, and then do the referral. Because the referral form for FSP is a 4-page referral form and can be tedious. And so we want you to make sure before you do all that work that the client's appropriate. If you've talked with the service area navigator, that also speeds up the case. Because when the navigator gets the referral, they don't need to then call you to get further information. They know the information offhand, and they know what provider they can then refer it to. Typically, if you send a referral in and you haven't talked about the case with the navigator, they're going to call you and consult. So it's best to just go ahead and call and consult up front so that everyone knows what's going on. Then you know what documentation you need to include, and then the client can be referred. So that kind of will help speed up the process for an FSP referral. Next slide. So our next level of care is our field-capable clinical services. Field capable clinical services, kind of, if you look at LA County's continuum of care, it's the next step in level of care, lower level of care than FSP. Many of the consumers transition from FSP to FCCS service as they progress through the recovery, and the need for services is titrated down. FSP programs are made directly through the delivering FCCS provider. Service area navigations have a list of what agencies in your service area are providing FCCS services, but those services are referred directly to the contract or directly operated providers who are delivering that service. So, thank you. The next level of care that I want to talk about is our PEI, or Prevention and Early Intervention, and this is actually the second wave of mental health, or second wave of services from the Mental Health Act was a prevention and early intervention, and its goal was to reduce 7 negative outcomes in LA County. So we want to reduce suicides, incarcerations, school failure and dropout, unemployment, prolonged suffering, homelessness, and removal of children from families. So that's the goal for PEI. Next. So PEI focuses on evidence-based and promising or continuing to find evidence-based practices. Specifically, early intervention services are directed towards individuals and families whom short-term, usually less than a year, relatively low-intensity interventions is appropriate to measurably improve a mental health situation in its early manifestations. So we're really looking to get to people before they need the intensive services. So next slide. And those are just some of the projects that we have. And then this is the double click one, the next 2 slides. So as the practices highlight, the ones that are highlighted are our top practices commonly used throughout LA County. PEI programs do not have an authorization process like FSP does. PEI programs are referred to by, or once a client goes into one of our directly operated clinics, they get screened for appropriate level of care, and the clients then would be placed into one of these prevention or early intervention programs based off their need. Next slide. Double click again. Although service area navigators don't have to authorize cases to for PEI programs, they can assist with locating specific practices. Next slide. Innovation is the last wave of MHSA funding. Innovation is primary goal, they're learning short time limited learning grants, projects that contribute to new practices or health approaches within LA County. So this last wave, next slide. This last wave of innovation programs focused on integrating primary care, substance abuse, and mental health services. So a lot of what we're doing now with healthcare reform, we kind of tried out in LA County. The integrated clinic model looked at if services were better served in an FQHC or a mental health clinic, but it had the one-stop shop approach. The IMHT, the Integrated Mobile Health Team, I'm sure this is going to perk some ears up. A lot of people call this the FSP on steroids. So, and why we say this is because it not only focuses on intense mental health and homeless needs, but it also has the primary care component to it. So it's really that full wraparound service for adults who are homeless. And then we have our integrated service management model, which focused on outreaching to specific UREP populations. All of these services are going to continue because we found them to be so successful. So your service area navigators also know how to refer to each of these models. So if you're working with someone and language or ethnicity may be the barrier to engaging them in mental health services, the integrated service management model uses non-traditional techniques to engage clients into mental health services. And then the IMHT program is primarily and solely for those who are chronically homeless and have mental health and physical health issues. So for IMHT, those services are directly referred through Jose Ramirez with CHEER. Everyone else, the service area navigators, have ways to refer clients. Next slide. Along with everything that we just talked about, service area, we have countywide services. Service area navigation is one of them. Our jail linkage teams, community mental health workers, planning and outreach engagement. A lot of people know your Emergency Outreach Bureau and our access hotlines, the SMART teams and the school suicidal threats. So there's an array of services that are provided throughout LA County. Next slide. Most importantly, what I want to talk about is how do you access your service area navigators. Service area navigators, their contacts change frequently, but we always have it up on our website, and so we want to make sure that you have the tools to be able to access that. So the first thing you'll do is go to the DMH website, then you'll click on our services. You'll click on countywide services. Next slide. From there, you'll click on the link that says Service Area Navigators. Next slide. Then you'll click again where it says Service Area Navigators. That gives a description of what the navigators are. Next slide.
Sorry.
And then you'll want to find this lovely sheet. This is also on a handout so you guys can actually read it, but I wanted you to be able to see what it looks like. On this sheet, you have every age group, and then you have your county. So it's listed by age group and then your counties and your service areas. So you start with service area 1, who your child navigator is, your TAY navigator, your adult navigator, and older adult. Older adult navigation is centralized, so it's one person who does all the referrals and linkages through older adult. So this is your ticket to be able to ask questions, get to know specifics in your service area, and it's a good thing to reach out and to get to know your service area navigators. They have a wealth of information that can share with you and help you walk you through the mental health services that DMH has to offer. And I think that's it for me.
Thank you, Amber. An amazing array of services and ways into services through DMH. So don't hesitate to contact Amber, and the navigator information sheet is on our website. So there's a one or two questions you might be able to answer through the chat, okay, Amber, and we're going to go to Dr. Sai. Dr. Sai is the Medical Director and Science Officer for the Substance Abuse Prevention and Control Division of the Department of Public Health with the County of Los Angeles. And he's a board-certified He's board certified in general adult psychiatry and addiction medicine. As a former APA SAMHSA Minority Fellow, he is also the founder of Forgotten Films, a film production company focusing on social issue projects, specializing in behavioral health. An amazing set of talents here today. So Dr. Tsai, take it away.
Yes, thank you. And I realized that we were running low on time, so I will try to be quick. So next slide, just a very brief overview of what we'll be talking about. Next slide. I wanted to start off, for those of you who are less familiar with SAPC, the Substance Abuse Prevention and Control, about who we are. And so we're the county agency responsible for facilitating substance use prevention, treatment, and recovery services for the county population. We contract with about 150 different contract providers over approximately 300 sites. We have one county-run site at the Antelope Valley Rehabilitation Center in Acton. So that's a little bit about who we are. Next slide. In prior presentations, I think Dr. Matsuda had referenced some of the substance use services available in LA County. This slide is organized by funding stream. Under General Medi-Cal, there's a voluntary inpatient detox that's available through general acute hospitals with the treatment authorization request. Medication-assisted treatments are also available under General Medi-Cal. These include medications for addiction such as methadone, buprenorphine, naltrexone, etc. Under Drug Medi-Cal, which is a carve-out, we provide outpatient substance use services, intensive outpatient services, as well as opioid treatment programs, otherwise known as narcotic treatment programs. I referenced the Drug Medi-Cal waiver here, which will enhance and improve our system of substance use care. I'll be talking a little bit more about this later on in the slides. But with the Drug Medi-Cal waiver, it would expand our services to include, it would expand Drug Medi-Cal services to include residential and withdrawal management, as well as certain medication-assisted treatment. And then currently, via other county contracted services, we provide residential services, particularly for the perinatal population, as well as detox or withdrawal management. Next slide.
Oops.
And
did I? Sorry.
Similar to the other speakers, we take a no wrong door approach. I think many of you are probably familiar with this, but there are multiple entry points into our system of care, and the idea is to create as seamless a system as possible. I think that elements of the Drug Medi-Cal waiver will help us in the future to better achieve this goal. Next slide. So I just wanted to mention kind of the referral flow for clients who you may be seeing who may require substance use services. The Department of Mental Health, DMH, actually cares for individuals with serious mental illness and co-occurring substance use. And so they are the appropriate referring entity for that population. The Department of Public Health, SAPC, cares for individuals with mild to moderate mental health needs with co-occurring substance use. Next slide. This is the substance use referral process. Kind of wanted to depict a visual of all the major players in the process. And so we have SAPC in oversight the health providers, so you all seeing clients, identifying individuals who may need SUD services. We have a centralized assessment center known as the Community Assessment Service Center, or the CASC. And so this is where many of you hopefully have been referring into and will be referring into. There are 19 different sites located in all spas throughout LA County. I provide the phone number here for how to get in touch with our CASCs, and they're really responsible for the initial triaging and referral to the substance use provider. So they help determine which level of substance use care might be appropriate for the individuals who are referred. And then lastly, you have the actual substance use providers who are providing the services. Again, we have over 300 sites throughout the various spas. Ideally, ideally, with any referral process, there's communication back to the referring provider. I think issues that I'll be discussing on subsequent slides will make this process easier, this information sharing process easier in the future. And just to highlight the no wrong door approach, self-referral, so individuals who just show up at our providers, for example, or who just show up at our CASC, can also begin the process of accessing care that way. Next slide, please. And so this is just a flow chart of how referrals work. And so starting from the top left, you have you all who are seeing clients, identifying individuals who need substance use services. If an individual has co-occurring serious mental illness, they would be referred to DMH. Otherwise, they would be referred to our Community Assessment Service Center by calling the number provided. The Community Assessment Service Center would then perform an initial assessment in order to determine the appropriate level of care, while also factoring in variables such as geographic location and client preference in order to refer the patient to a specific provider. Ideally, the CASC would then notify the referring provider of the outcome and where the client's placed. The substance use provider would deliver the services and then ultimately communicate back to the referring provider in order to close the loop and ensure appropriate communication. Next slide. Care coordination, just wanted to mention this important aspect of care. I think with health reform, there's an increasing focus on the need and benefits of better coordinating care across systems, so physical health, mental health, as well as substance use, bi-directional communication, and efficient information sharing is important here. I think that I understand that many of you are case managers who will play an increasingly important role in facilitating care coordination for your homeless clients.
Hi Marina, it's Beatrice calling, Beatrice Velasquez. I have left you a message before you guys.
Hang on, Dr. Sai. Okay, Gary, go ahead.
Okay, great. Next slide. I had alluded to changes in our system of care in the future. This slide emphasizes some of the new changes that are influencing some of the system-wide changes that are occurring right now. The drug Medi-Cal waiver I had mentioned previously, the move towards more of a chronic disease model of addiction care, healthcare reform obviously in addition to parity, and just a growing recognition that we need to address all aspects of an individual's health, whether it's physical health, mental health, or substance use. Next slide. And so with this in mind, the drug Medi-Cal waiver is something that the state has recently submitted to the federal government in order to expand and enhance our system of care in a number of ways. And so these slides will just kind of paint a picture for what's to come in the future. One of the big changes that we're really excited about is expanding to a fuller continuum of substance use services including withdrawal management. And so moving from early intervention and prevention all the way to inpatient services, and then everything in between. So outpatient services, intensive outpatient services, residential services. I think traditionally in the past, it's been very difficult to have a full continuum of substance use care due to funding issues, funding challenges. And with the Drug Medi-Cal waiver, there's funding through expansion of Drug Medi-Cal to provide some of these services. Earlier I mentioned that residential as well as withdrawal management services would be provided in the Drug Medi-Cal waiver, assuming that it's ultimately approved by the federal government. Next slide. Another foundational element of the waiver is taking more of a biopsychosocial approach. I think traditionally in addiction, the psychosocial component has been more of a focus, with less of a focus on the biomedical aspects of care. With the advent of medication-assisted treatments, there's a realization that we can combine biomedical approaches with psychosocial interventions, similar to what's done in mental health, in order to achieve better outcomes. And so part of this will involve enhancing the workforce of our providers. Next slide. Another element of the Drug Medi-Cal waiver is really a foundational reliance on the ASAM criteria. So the American Society of Addiction Medicine has a multi-dimensional set of criteria for assessing clients, similar to what's done in other areas of healthcare already, but it helps to organize the assessment process and also bases care based on medical necessity, as opposed to other things such as funding streams, as has traditionally been the case for the treatment of substance use. Next slide. And so just to put everything together, the Drug Medi-Cal waiver will improve access to services. It highlights quality in terms of requiring the development of a quality improvement program as well as a utilization management program, which we're developing now. The key goal of the Drug Medi-Cal waiver and of our system of care in the future is to provide the right services at the right time in the right setting for the right duration. This is something that actually President Obama has kind of alluded to recently in terms of precision medicine, but just individualizing care. Also, in terms of providing care according to the chronic disease model, the Drug Medi-Cal waiver will also allow for payment for case management services as well as recovery support services, which we think will be an important aspect of providing a full continuum of substance use services. Next slide. I had mentioned the importance of care coordination. Information sharing is going to be key in terms of being able to coordinate care across systems. So in substance use, we have 42 CFR as well as HIPAA. So just making sure that we are addressing our need to communicate across providers and balancing that with patients' preferences in terms of privacy. And the development of a universal consent form, which we're currently working on, will, I think, be very helpful in facilitating this process of communication. And then lastly, I'd mentioned just the need for us to expand our workforce and improve infrastructure in terms of getting, in particular, physicians, primary psychiatrists, and physician extenders on board and to address some of the biomedical aspects of substance use care, for example, medication-assisted treatments. And I believe that's the last slide. And sorry, I know we're over, but thank you for this opportunity to speak to the group.
Dr. Sai, thank you so much. If you have a couple of minutes, there are a few questions for you. Dr. Sai?
Yeah.
Okay. One is what acute hospitals can provide voluntary inpatient detox?
That has very big challenge. We actually have not been able to identify hospitals that provide that service currently. There are barriers in the way that that policy was developed at the state level that we need to work through. And so while that is a benefit, it's not being utilized to the degree that it needs to be. And that's something that we're in ongoing discussion with the state about.
So right now, no hospitals can?
They can, but practically they aren't. I mean, part of the reason is the treatment authorization requests. I mean, theoretically, this is happening in emergency rooms, where emergency room doctors generally don't have the ability or interest to submit a treatment authorization request and then wait for a response in order to provide services. And so I think there are issues with this benefit that need to be worked out before it can be accessed to the degree that it needs to be.
Okay. And a couple of questions about housing. One question is when individuals are seeking detox programs with medical beds, are there openings?
So residential beds and detox beds are limited. We're very aware of that. That's one thing that we're hoping that the drug Medi-Cal waiver can help us improve. In addition to just the need to invest more resources into substance use services.
Okay. And Amber, this was a question for you as well. Do your services include housing for those who are homeless? Does DMH have any housing for those with mental illnesses? Oh, let me unmute you.
Housing program, they must receive mental health services as well. SSP has a component where housing supports are offered, but we also have individual MHSA housing that are full complexes that are low subsidy. So yes, we do have housing options available. However, consumers have to have an open DMH case to be eligible for housing.
An open DMH case to be eligible.
Correct.
Okay. Okay. I don't see any other questions that we missed. I want to go, since we are over time, I want to thank you to our presenters, Dr. Matsuda, Dr. Rizzo, Amber Anderson, and Dr. Sai. Thank you so much for your time. This is an amazing amount of information, and I know this is a big overview, especially if someone is new to the area of behavioral health. We are talking about doing an in-person training that might go further into depth or have more time dedicated to your questions. But we wanted to start with sort of an overview of where things were in terms of behavioral health services in the Los Angeles area through Medi-Cal for homeless service providers and housing service providers. So that we see this as really a step one. As I mentioned, all of the materials in this recording will be online for you to access through UHHPLA.org. And we will be offering additional training as well through UHHP. For those of you interested, we'll be offering motivational interviewing in May, further the in-person physical and behavioral health training that I just mentioned, as well as a training for supervisors and a cultural humility and person-centered language training. These are coming up throughout the summer, basically beginning in May and through August. We are so grateful to have you with us. I apologize for GoToMeeting. It was just not cooperating at all today in terms of muting, so I apologize to our presenters for some of the noise that was coming on board, and appreciate your patience. we will be sending you links to the materials as well as the contact information, which Dr. Rizzo and the others were so generous to offer their contact, as well as there's multiple handouts online how to access these services, access the navigators, and so forth. But we hope this was helpful to you. Do continue to send us questions or the kinds of information you would like more training on, and we'll do our best to provide it. And for now, thank you again.